Today we are going to study about an important topic called cervical and cerclage. What is cervical and cerclage? It's basically a surgery done for cervical incompetence. Okay, so cervical encerclage is a surgery which is basically done for the cervical incompetence. So generally, when does it done? What is the indications? What are the indications when we do? What are the indications we do? First and foremost, you have to do a scan. So it is the time which is generally done is 12 to 14 weeks. It is done 14 weeks. Before doing encerclage, you should make sure the fetus is live. The fetus is live, and anomaly scan should be normal. Okay, so that's why sometimes after 18 weeks also they do. After 18 weeks also they do. Okay, and you should make sure there is no any vaginal infections. There is no any vaginal infections. Okay, so there are two types of surgeries. There are two types of surgeries. One is modified Shirodkar, and second then is McDonald's. Okay, so now for whom you are supposed to do? What is the indications of doing surgery? Indications of doing surgery, as I told you, first and foremost there should be a live fetus. Second thing is anomaly scan. Anomaly scan should be normal. Okay, so these are the basic things. What are the other indications where you have to do surgery? Very initially, that means in the 1999, the indications were prophylactically they used to do surgeries. In which conditions they used to do? For example, if there is a multiple gestation, in placenta previa, they used to do. But now it is not done. In 2000 they have come with the guidelines. In 2007 basically 2007 they have come with the guidelines. They are telling that whether there should be a history or USG report, documented USG report. Based on these two only you have to do a cerclage operations. So what is that recommended guidelines, RCOG? This is very important. RCOG 2011 guidelines. What they are telling is, first and foremost, history should be there. There should be abortions. There should be abortions of more than three or more than three. More than three abortions should be there. Second trimester losses. Okay, but if it is less than 2 or 2, you are not supposed to do this. Okay, so this is one criteria. Second criteria, they'll have only one abortions, or we can tell preterm delivery. Here also you can write abortions or preterm delivery. Along with this, if there is a sonography, that means if there is a TVS scan in which the cervix is in the form of a T or V or U detected on USG, or cervical length less than 25 mm, then you have to do the surgery. Okay, so next, if the patient is if she doesn't have the history, only accidentally, if the cervical length is less than 25 mm, then you are not supposed to do surgery. Okay, now if the patient is having a funneling of os, but cervical length is more than 25 mm, then also you are not supposed to do. Okay, and what is a rescue cerclage? Rescue cerclage is basically done around 16 to 28 weeks. This is important, you have to remember this. Rescue cerclage is done at 16 to 28 weeks. So this rescue cerclage, basically it should be that almost 3 centimeter dilated. It should be 3 centimeter dilated with bulging membranes. Okay, only the senior obstetrician has to do this rescue cerclage. Okay, so now these are the surgeries which I told you. Or that these are the two of surgeries which I told you. These are generally done on vaginal surgeries. Okay, so now what are the things that I'm telling is abdominal cerclage. This abdominal cerclage basically done in the conditions where cervix is not good, that is there is an amputation of cervix or previous failed vaginal cerclage. And third thing is if there is any fistula. Okay, what is the type of fistula that we see in the case of cervico-vaginal fistula? Cervico-vaginal fistula, if you see, then also you are not supposed to do. So you are not supposed to do vaginal, so you are supposed to do abdominal cerclage. Okay, so now we'll study about what is modified Shirodkar. Modified Shirodkar surgery. What is modified Shirodkar surgery is basically, in this, first thing, of course, we do under anesthesia. Generally it is spinal anesthesia or block. What type of block? It's caudal block. Okay, some people will also tell we will give general anesthesia, but you can give like short general anesthesia. Short general anesthesia also is given. So you have to keep the patient in lithotomy. After lithotomy, under proper vision, you should identify the cervix. Okay, you should identify the cervix. Now you know this is the vagina and this is the cervix. So what you do is this cervix as well as the vagina junction, anteriorly and posteriorly, you take a small incision. After taking a small incision, what happens? You go submucosally and you take a knot here at the level of internal os. Okay, so anteriorly and the posteriorly you take a transverse incision. In the transverse incision, you will pass a non-absorbable sutures. Non-absorbable. What is the non-absorbable sutures? It may be silk, it may be ethibond, it may be nylon. Most commonly used is mescaline tape. So this mescaline tape is the one. Generally what we do is we pass anteriorly to the posteriorly and posterior to the anterior, the submucosally. So from passing the submucosally, that what happens, after that we will bring anteriorly and forms a reef knot. This reef knot is done. So this is nothing but called as modified Shirodkars. In this modified Shirodkars, what happens, you require little bit of expertise and you are taking the incision on the cervix and vagina, and actually you are pushing the bladder. Here is a bladder, right? So the bladder is pushing up. At the left, the internal os, you are putting a stitch. Okay. This, some people are telling that this stitch is kept in situ even after delivery by doing cesarean section, so that for the next pregnancy also it's useful. But ideally we have to remove it, and next pregnancy you have to take care later. Okay, so this is about the surgery, that is modified Shirodkar surgery. Okay, now what is the suture material used? Is this thing. What is the needle used? Here there is a special needle called as Shirodkar needle. Shirodkar needles or aneurysm needle. So these are the two needles generally we use, and we take a reef knot and we close it. Okay, now the incision whatever it is there, here we close it with the catgut. We use it a catgut and we bury the sutures. Okay, so this is about the modified Shirodkars. And next is McDonald's. Generally we do it commonly, even in our hospital we do. what we do is basically here the expertise is not required. Only we do is a purse string sutures, and the success rate is also very good. And it's not about the success rate, even the complications are also very less. So this McDonald surgery, you think this is the cervix, you take a knot here, 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 and you tie it off. So it's like you take a purse string. So purse string, how we close the peritoneum during cesarean section. So just like that. So and this purse string sutures we take and we tie it, and here you no need to take a transverse incision anteriorly, posteriorly, nothing. You just take a bites and you tie it off. Okay, this is the McDonald's, and here also you use a non-absorbable sutures. The success rate is around 85 to 90%, and the complications are also less. Complications are less, and no need of expertise. Okay, that you have to remember. So this is about the McDonald's. What are the other type of surgeries that we know is, one is Wurm's, that is WURM's, Wurm's stitch. Worm stitch, what you do is you take a stitch at two places. One is anterior posteriorly and left to right. So this is worm stitch. And next is rescue cerclage. I told you rescue cerclage is basically it is done if the patient is having cervical dilatation of 3 centimeters and bulging membranes. If there is a bulging membranes, we do rescue cerclage using the Foley's bulb. What they do is basically, you think this is the cervix. Now what happens? The membranes are coming bulging like this. Okay. Now what you do? You put a Foley's bulb and you push it. Then what happens? It becomes like this. So the bulging membrane is pushed up because using this Foley's like this, and then you take a stitch, you take a cerc. So this is how the basically we do the rescue cerclage. Okay, so the rescue cerclage is done, and we do transabdominal cerclage. Transabdominal cerclage, basically I told you which are the conditions you have to do. Here fenestrial incision is taken. After taking fenestrial incision, you put a cervical stitch at the level of internal os. Okay, so now what is the complication of transabdominal cerclage? First and foremost, first thing is, in transabdominal cerclage, for always the patient should be delivered by C-section. Even if there is a miscarriage also, that is abortions also, what we have to do is we have to remove stitch by laparotomy. That you have to remember. Okay, next what are the other surgeries? Transabdominal cerclage is done. Next is laparoscopy. We use laparoscopy. Using the laparoscopy we take a stitch, and next using the robotics. Okay, here comes the MCQ. What is the type of surgery which is done in the non-pregnant women for cervical and cerclages? Lash and lash operation. Lash and lash operation is the one which is done in the case of non-pregnant women. Okay, so now what are the contraindications? As I told you, first is death fetus, next is anomaly, if there is a cervical dilatation more than 3 centimeters, and if there is any vaginal infections, and if there is any chorioamnionitis, and if she is having proper uterine contractions. What is proper uterine contractions? That is one contraction which is lasting for 40 seconds. 1 to 2 contractions. You can write 1 to 2 contractions lasting for 40 seconds. Okay. And active preterm labor. So these are all the conditions where you are not supposed to do the cerclage. What are the complications? After putting a stitch, the stitch can be slippage. There is a slippage. It can slip. Second thing is membranes can be ruptured. Ruptured membranes. Third is abortions. Fourth is preterm labor. That means you iatrogenically you can rupture the membranes, iatrogenically you can cause the induce the labor also. So there will be preterm labor. What will be late complications? You are just traumatizing the cervix, so there might be chance of cervical dystocia. Cervical dystocia will be there, and during the labor, if she's having adequate contractions, if for example you have done a cervical stitch, you have put a cervical stitch and then you have sent the patient, and during the term she's having adequate contractions but there is no cervical dilatation, so there might be chance of uterine rupture. If she is in the hospital or if she is in the clinic, what happens? Immediately cervical stitch is removed. But if she is at home, there might be a chance of uterine rupture, but very rare chances, and rarely it can cause even necrosis of the cervix. Okay, these are the complications. See, the cervical operations or cervical incompetence, the surgery what we do, it appears to be very simple, but actually you should require a little expertise to do it. Doing surgery is not a big deal at all, but after that how do you manage matters a lot. So what you have to do is, first off, post operatively you have to give sedation. That is not important. Very important is, this is tocolytics. You have to give tocolytics. What is the tocolytics that we give? So isosuprin, it's also called duodenum. Next is ritodrin, 10 mg you have to give. Okay, this ritodrin generally you have to give 8th hourly for almost like for 2 days. 2 days, but some books are telling that you have to give ritodrin for almost for 1 week. In our hospital we follow this. For 1 week you give ritodrin or duodenum, and of course we have to give progesterone. See, this ideally what happens is tocolytics you have to give pre-operatively only. Sometimes you have to give pre-operatively. Even this progesterone also you have to give pre-operatively. What is the drug we give is alpha hydroxy progesterone capriot. How much? 500 mg we give in our hospital, but 250 to 500 mg you can give. 250 500 mg you give injection, and after that you can continue with orally you can give. So what is that? Dinogestrone. This also is used in hospital. It's little costly, so we have to give at least weekly once. Okay, so that you have to do. So dinogestrone you have to give sorry, this is not weekly once, I'm extremely sorry, not this one weekly once. This actually you have to give twice daily. Okay, there is one more drug, you don't need to remember this, that is alastronol. This you have to give weekly once. So I've been confused with that, weekly once. So you have to give this injection. Post operatively also 1 dose you can give, and after that you can shift around that of oral drug. So you can give twice daily for this, and you have to give bed rest for 48 hours. 48 hours bed rest, and of course antibiotics, because you have done surgery, so antibiotics. Then you have to tell bed rest. Okay, next, what you are like on discharge, what you have to tell? First thing is you should come like as usual, antenatal ANC visits you have to come, and very important, coitus should be avoided, and rough journey should be avoided, and periodic USG has to be done for fetus. Of course, everything, fetus, cervix, everything. Generally, the cervical stitch I told you, after 37 weeks is term. So cervical at 37 weeks you have to remove the stitch. But if there is a floating head, you have to remove stitch inside the OT. Remove stitch inside OT. Why? Any guesses? If the head is not well applied, floating head is there. If you try to remove the cervical stitch, what happens? There might be a chance of dreaded complication, that is cord prolapse. Okay. So this is about the cervical incompetence.